So my name is Bob Walter. I'm in the Division of Pulmonary and Critical Care Medicine, and this talk springs out of a national effort on the part of hospitals to make sure that best care, guideline-based care, is really getting implemented, and particularly with the arrival of Ochsner and its interest in making sure that patients are receiving high-quality care. We're starting to see some changes here on our campus, and particularly within the critical care. I wanted to talk about a couple of different things that we're doing within the critical care service line to hopefully improve care in all of the adult ICUs. So we're going to talk a little bit about why are these recommendations about ICU care, and why are these quality measures. And particularly sepsis is one of those quality measures that is a very particular quality measure, but there are other efforts like the pain, agitation, delirium, immobility, and sedation effort that Society of Critical Care Medicine is trying to push with implementation of the ABCDF bundle, which is supposed to reduce the complications of being in the ICU and improve mortality. We'll talk a little bit about what does it mean to be compliant with these guidelines, particularly in the ICU, and what are some of the tools that we are developing to help the ICUs actually implement some of these changes. I think one of the reasons I like critical care medicine is how much things have changed. I think many different people have said this before. If I were doing what I did as a resident and a fellow, I would probably be sued for malpractice because I was killing people. We used to sort of think about the physiology, which I think is a very useful exercise, and work to actually take control of this environment and maximize, supranormalize all of the different systems. So we would have people intubated and sedated and paralyzed and drive their hemoglobin up and drive their cardiac output up, watching the extraction normalize or supranormalize their blood gas, even to the point of rupturing their lungs. And we've learned through the series of seminal articles that maybe we didn't need to do that, that maybe what we need to do is actually just support people enough that their metabolic needs are being met, and that we're using the lowest but still effective dose of all of our interventions to make sure that the body can actually survive this event. And once the body returns to some sort of homeostasis, try to remove as many of those interventions as possible. And I'll list here some of the things that have changed. We used to I remember being on call for Pulmonary as a resident and doing everything I can to normalize blood gases, including using rather large tidal volumes and the like. Subsequent to that, the ARDSNet publication came out that showed maybe we were just beating up the lungs and actually letting CO2s rise and tolerating a little bit lower oxygen levels was actually associated with a better mortality. We used to give a whole bunch of blood, and then the TRIC trial came out that showed us that target hemoglobin of 7 in a general ICU population was better than aiming for 9. Resuscitations, we used to supernormalize stuff, and we didn't necessarily go all that fast. And the early goal-directed therapy trial showed that we ought to do it a little bit faster than perhaps we were doing it before. And then the FACT trial and some of these other articles gave us some additional insights on how best to manage people after that early resuscitation effort. And as you kind of go on through this, there are lots and lots of other interventions that have been shown. Some of the stuff that we did shown to be ineffective or deleterious, and new interventions have been shown to be helpful. And this is just an abbreviated list. So of course, doing ICU medicine, I would argue, is increasingly complicated. Even if you know all of this, to sit there and go through in your mind and really make sure you hit each of these high points, that you're making sure that they're on appropriate ulcer prophylaxis, that you're de-escalating the antibiotics, that the sedation meds are right and all, is very difficult. And it's easy to miss stuff, even if you're well versed in it. So with this as background, you have to recognize that payers, and particularly the 600-pound gorilla Medicare, are really moving towards value-based reimbursement for care. And there are two things that I just sort of highlight here is now they have the hospital inpatient quality reporting program, and there are two elements to this. there are the reporting requirements where we have to tell Medicare how we're handling this, how many events we have of this particular instance, and how we treated it, where we just reported. And then there are other things that Medicare actually determines or alters reimbursement as a function of how compliant you are, not just with reporting, but with their recommended interventions. And patients are being increasingly encouraged to act like consumers and to go shop for care. And so this is a real push on the part of Ochsner, to really make sure that we are documenting and getting credit for the work that we do, to make sure that the patients are having an experience that they would recommend to other people, so that they actually do recommend to other people that they come to our hospital and see us. And if you're ever curious, and I'll show a couple of slides from some of the area hospitals, including us, if you're ever curious, you can go to the Hospital Compare website and actually look at that published data. So when you look at possibilities for intervening and improving quality of care, sepsis as a core measure is a very tempting place to intervene. It's a very common diagnosis. You see there's nearly 1 million cases of sepsis every year, and it's at least as common, if not more common, than CHF in terms of incident cases. It's the 10th leading cause of death, with a mortality associated with the diagnosis around 30%, higher if you have septic shock. And if you look across the United States, as many people die with sepsis as an acute myocardial infarction. And you think about MI, the cardiologists are held to these standards of door to balloon time and so on. And now the ICU doctors, because this is such a public health problem, are being held, increasingly held to their own set of standards. And the hope is that maybe we can do something about that $20 billion plus a year in hospital costs that are being spent. So Medicare came out with this dreaded Sepsis Bundle. Its technical name, I copied that from the CMS website. It's the Severe Sepsis and Septic Shock Management Bundle, a composite measure, which sounds like a good story. Basically, Medicare looks over all of our charts to see how many people met the definition of sepsis, severe sepsis, or septic shock. And in the top, when they report a number, they report a percent. And in the top, the numerator, they report all the patients who received all of the interventions that they recommend in the right amount of time. And in the denominator are all the people who had been coded or should have been coded as sepsis, severe sepsis, or septic shock. So if you're intervening on everybody, the numerator and the denominator are the same, and you'll see that's really not the case. There are some exclusions from these. If you go to palliative care immediately, if you're transferred to another hospital where you don't have enough time to actually have done all this, those cases are actually excluded. And I'll show you what our numbers are and what the national and state numbers are. So they use severe sepsis and septic shock. These are older terms that just recently are being displaced a little bit, but of course regulatory agencies are not as quick to change as the practice of medicine. But I think that we can appropriately sort of back into using the more modern definition or the more current definition. So what is sepsis? This is sort of the evolution of the diagnosis. Prior to 1992, there really wasn't a good consensus definition. And so they got together, a group of people from around the world got together and came up with a definition. I'm sure they stayed in a nice place because no academic conference ever happens in like a not nice place. So they decided that they wanted to define sepsis as a documented infection or suspected infection plus inflammatory criteria. And as you look at these, you realize that you could easily just go outside and run around the block, and you would probably have a tachycardia, tachypnea, a little bit of a leukocytosis from demargination, and your core temperature, especially in the middle of August, would probably be up a bit. So you can actually have this inflammatory response. About 10 years later, 11 years later, they met again, I'm sure in another nice place, and expanded on that because that's what academic medicine does. It takes something that's working reasonably well and makes it a little bit more complicated. And they added all of these other things. And you notice as you look through this that they're actually starting to move from inflammation to tissue injury or organ injury. So you start to see things like changes in the creatinine or evidence of acute kidney injury showing up. And then finally, in 2016 in JAMA, when the third definition was published, they really moved away from inflammatory markers over to a measure of organ failure. And so here, sepsis is about, again, documented or suspected infection plus organ failure. So in a non-tabular form or non-list form, this is what the SCCM and international societies' definition of sepsis is. Sepsis is a life-threatening organ dysfunction caused by an inappropriate or dysregulated host response to the infection. So if you had pneumonia and you had a fever and you were tachycardic and the like and a little bit inflamed, but all your organs are still working, you really don't have sepsis. That's your body having an appropriate response to that ongoing infection. In contrast, if you have a little bit of a pneumonia and you develop ARDS and acute kidney injury and your liver dies and you're totally disoriented and everything like that, that's not such an adaptive response to the infection. And that person actually has organ dysfunction and would be appropriately labeled as septic. Because this is a reporting requirement to CMS, I would be careful about the use of this term, because if we say so-and-so septic when they're just febrile in response to a normal infection, that's adding to our denominator, and the interventions that are required to get into the numerator may not be appropriate in that person. So make sure you're appropriately restrictive in the use of that term. So the way they operationalize, a word I love, that definition of sepsis is basically a change in your SOFA score of 2 or more points, and they know from deriving the SOFA score that a change in SOFA score of 2, a worsening organ failure associated with 2 points on a SOFA assessment, is associated with an increase in mortality of about 10%. So they felt that was clinically meaningful. And remember that the infection can happen from any infection, whether bacterial, viral, fungal, or other. It's a dysregulated response to that infection. So septic shock, another term that Medicare CMS is embracing, is a subset of sepsis. So you have to have sepsis to have septic shock, which makes sense. And for the more junior people in the room, I have there the definition of shock. I like to think it as simply inadequate delivery of oxygen to the tissues. And there are 4 basic physiologic mechanisms: cardiogenic shock, hypovolemic shock, vasodilatory or distributive shock, and obstructive shock. And the way the SCCM et al. Define septic shock, it's a subset of sepsis with particularly profound circulatory, cellular, and metabolic abnormalities. And these people are associated with a much greater risk of dying than simply in sepsis alone. And they operationalize that term by saying septic shock are the people who are on vasopressors to maintain a MAP of 65 and have a lactate still greater than 2 in the absence of hypovolemia. So I take this definition to mean if you haven't volume resuscitated somebody, you cannot label them as yet as having septic shock, or you haven't assessed their volume status. If you have not made sure that hypovolemia is not present, you cannot say that they have septic shock, which is useful when dealing with the CMS side of things. And just as a parenthetically, it's important to remember that septic shock typically is, you'll hear people say that it's a distributive shock, and it certainly has a distributive component with vasoplegia in the extreme form, but generally there's a component of hypovolemia. People are febrile, they're not hungry, they have anorexia, they're not taking in fluids, they're going to be hypovolemic, plus they have capillary leak, and a lot of the serum moves out into the tissues, so their filling pressures are lower. So there's usually a component of hypovolemia, they have the distributive component, and there are myocardial depressant factors associated with sepsis. So when you're resuscitating a septic patient, you really need to think more broadly than just distributive shock. So just to reiterate and remind you of what is the definition of sepsis, historically it was this SIRS with infection. It moved to using the SOFA score, and they actually argue for using a CUSO score to simplify things, to see whether if they screen negative with the quick SOFA, then you don't have to do the SOFA calculation. But now with everybody having now with everybody except for me having a smartphone with apps on it, calculating the SOFA score is really easy at the bedside. And so I'm not sure how much value added there is to the CUSO. So what goes into a SOFA score? Here they are, the 6 major organs: lungs, coagulation, cascade, liver, heart, central nervous system, and renal. And you see as you get worse, you get more and more points added. And there are apps that will calculate this for you. You see adding 2 points really isn't all that hard. If your platelets dip below 150, there's you a quick point. And if you're on oxygen to maintain sats in the low 90s, more than likely your PF ratio is below 400. And so you quickly get 2 points on it. So just a word about the dysregulated response. You should recognize that fever and all are generally thought to be fairly adaptive responses to the infection. And the sepsis is a maladaptive response. And that sometimes can make it a lot harder to recognize that the person is actually septic. You can have hypothermia, which sometimes looks reassuring because you don't see that big spike on the flow sheets in EPIC. It just is sitting there along the baseline. I almost wish that in EPIC that the lower limit that they reported was actually somewhere around 94, because then you would see the dips, and that actually might be more concerning. Right now it just sort of plateaus and it just sits at the bottom and you don't realize how low they've gone. They can be leukopenic and things like that that make it so that it's not screaming that this is sepsis. And as you're looking at identifying someone as having sepsis, you need to recognize that really the cornerstone of treating these people is early antibiotics, achieving source control quickly, and supporting their body through this maladaptive response. Antibiotics, as those of you who have rounded with me in the ICU, need to be chosen appropriate to their source and dosed in a proper and timely way. So we often use Vanc and Pip/Tazo. That does not cover everything, contrary to maybe what our practice habits would suggest. My favorite example of that is pneumonia. The more likely, the closer you are to being admitted to the ICU, the more likely things like Legionella species are the causative pathogen, and there's no Legionella coverage in Pip/Tazo. So you really have to go through that exercise of where is this infection likely coming. From that, you can know the likely pathogens and then choose an appropriate antibiotic regimen. Source control, often antibiotics are able to do this. But as you think about hepatobiliary sources or even pneumonia with parapneumonic effusions and empyema, there may be you may have to engage our IR surgical colleagues to actually help you get on top of the infection. And then lastly, resuscitation. The goal is to make it so that people have adequate tissue oxygen delivery so that the cells can actually function normally and not die and propagate this cascade. And you need to think about the different mechanisms that you're trying to resuscitate. The article that really got the early resuscitation efforts going was the early goal-directed therapy article with the senior author of Manny Rivers. And if you look at their resuscitation algorithm has only one reference, and it's to SCCM's consensus statement. So there's not a lot of trial, sort of primary research going on. There's not a lot of primary research to support SCCM's original early goal-directed algorithm. It's just that you need to get in there and actually treat this as a medical emergency and get on top of things, getting the antibiotic, source control, and restoration of adequate tissue oxygen delivery. We're not sure exactly which interventions are best done when, and we'll talk a little bit about that in just a minute. So this is the sepsis bundle. It keeps evolving a little bit over time. Recognize to get in the numerator, you have to do all of this, or you don't get in the numerator. And you want to be in the numerator. It's the good place to be. And again, I would emphasize also that this is a reporting mandate. This is not something that will, whether or not you report it, will impact how the hospital is reimbursed. Whether or not you get 50% or 25% won't impact how the hospital gets paid. And so you really should take the time to think about each of these interventions that you're being prompted to consider and decide whether or not it is appropriate in your particular patient, because they may not be appropriate in every patient. In fact, they probably aren't appropriate in every patient. So if a person meets the diagnostic criteria for severe sepsis and recognize that coders come behind us and look through the chart to see whether they think they meet the definition of severe sepsis, which really I think is fairly analogous to the SEP3 definition of sepsis, because they both involve organ dysfunction. Within 3 hours, you have to collect a lactate, you have to draw blood cultures, and you have to start appropriate antibiotics. And if within 6 hours, you have to get a lactate follow-up if the first one was abnormal. So that's if they have severe sepsis. If they have septic shock, you have to do all of these, but you also have to give 30 mils per kilo of crystalloid. You have to start vasopressors if the hypotension persists after the 30 mils, and you have to come back and do a repeat volume assessment. And I will tell you, they are evolving because this used to be prescribed. They used to tell you what combination of measures you had to do to actually move from just denominator to numerator and denominator. And now a repeat assessment is considered sufficient because CMS now acknowledges that there are a bunch of different ways to do this, and none has been proven superior. So what is the evidence for these prescribed interventions? I thought this was a nice article from Annals, and while I don't like necessarily putting in tables, I think this is pretty instructive. So you notice this row is about the number of randomized clinical trials. This is the number of observational studies. And this is the level of evidence by the usual measures. Serial lactates, there are 2 randomized trials looking at whether or not serial lactate improves outcomes, and 7 observational studies, and that qualifies as a low level of evidence. 30 mils per kilo with the amount of fluid that they say you must give everybody. There's no evidence to support that particular number in an RCT. There's some observational studies, and again, is low. And then you look at these other things. So there's really not a whole lot that shows that these particular interventions are the best measure. And if you're going to require somebody to do something, you really ought to be pretty sure that this is actually the best thing that they can do and not just one of many appropriate things that they could do. And treated as a bundle, there are no clinical trials, and I'll show you a little bit of observational experience. And so ultimately, the bundle, its components are not well validated, and it, treated as a group of interventions, is really not very well validated. So does this bundle work? Ultimately, it depends on who you ask. I borrowed some of this information from a discussion that happened at SCCM. They had a nicely moderated session on this, and they had a pro-con debate. And ultimately, the 2 speakers agreed that the SEP 1 reporting requirement is a well-intended effort that can be improved upon. Nobody disagreed with that. This is data out of New York. New York started ahead. The state of New York started ahead of CMS requiring public reporting for sepsis in these interventions. And you see the mortality over here, and initially the mortality for the diagnosis of sepsis was somewhere around the 25-30% that is typically reported. And during the terms of the reporting, as people were starting to actually pay attention, there was a slow reduction in the mortality by about 5 percentage points. And the pro people would argue that this is evidence that, in fact, the mandatory reporting changes outcome. They won't tell you that that means that every element of the bundle is equally important and it is the best, but this mandatory reporting, they would argue that it works. In contrast, other people would say that this is actually a wonderful example of ascertainment bias. When you don't have to report, you're not necessarily sitting there and looking at those gray cases where it's not clear, it's not black or white whether the person's septic, and you're going through and you're labeling people as having sepsis when in fact they're on the cusp, and as a result their expected mortality is lower. So you're starting to include in your definition a bunch of people whose cases would never have been included before. And that shifts the mortality downward even if the intervention doesn't have any impact at all. And to support that, they actually took some of the data and looked to see whether or not doing everything actually was associated with a better outcome, or conversely, not doing everything was associated with a worse outcome. And in the multivariable analysis, you see that the p-value in the analysis was 0.2, so relatively high. So that ultimately what they're saying here is that non-compliance with the bundle was not associated with a worse outcome. And so there's debate as to whether or not the bundle works, but it is, I think, a well-meaning effort. It may be that some parts are actually more important than other parts. You see here that the amount of time that it took to administer antibiotics was associated with a rising mortality. So if you gave appropriate antibiotics up front early within the first hour, your mortality was on the order of 23, 24%. And if it took you 12 hours to get the right antibiotics, that mortality had gone up, call it 6 points, if I'm doing the math right. Suggesting that actually the antibiotic administration is especially important. In contrast, if you look at time to completion of the bolus of fluids, no matter how long it took you to give the fluids, there was no shift in mortality, suggesting maybe fluid resuscitation is in fact not as important as antibiotic administration. And in fact, there is an argument going on in the critical care world as to whether or not any fluid resuscitation is important, or maybe a targeted fluid resuscitation aimed at very specific physiologic goals. So this is from clinicaltrials.gov. I searched no fluid in sepsis and came up with 283 different trials going on that are angled to see how little fluid ultimately you can get away with when someone comes in sepsis. So I would argue that the compliance with the fluid resuscitation component is not nearly as important as the antibiotic administration. So that's just my own 2 cents. So where are others and where are we in terms of compliance with this? The national average is at 51%. Louisiana as a state is at 46% in terms of compliance with the bundle. And just for sake of comparison, I chose a little bitty hospital in Boston, Mass General, to see where they were. And it's a teaching hospital, so they're at 35%. So if we kind of use that as a measure, we can look at us here in Shreveport. Ochsner LSU Health is at 27%. Willis-Knighton slightly higher, but again, these are fairly close to what Mass General experienced. And for some reason, Christus is at 63%. I don't know well enough what's going on over there, whether they had put in place an effort to actually make sure that every time the word sepsis gets used, somebody gets 30 cc's per kilo of fluid. I'm not sure. So to take away from this, the terms sepsis and septic shock mean very particular things. And I think they should be used appropriately, which means use it when you need it when you use it. That's important for 2 reasons. One, we should have the right diagnosis. It's to make sure that we treat our patients appropriately and we're doing the right interventions, but also to make sure that we get credit for what we did, and CMS reporting is appropriate. I do think it's important to note that sepsis is a medical emergency. You see that in the worst thing. If you take your time giving antibiotics, your patients are going to do worse. And ultimately, like I said, we're going to be graded on our response to the label of sepsis or the diagnosis of sepsis. And while they're imperfect, they are published, and patients will be aware of it. So to change subjects a little bit, so that's a very particular core measure. Sepsis is something that that CMS has embraced and said, this is what we want you to do. More generally, CMS is also tracking a bunch of other measures related to your time in the ICU, everything from CLABSIs and CAUDIs and VAEs and all these other sort of things. And the risk of developing a lot of these sort of downstream events is a function of how long you spend in the ICU. And there are a number of different interventions that have been shown to help reduce your time on the ventilator and consequently your time in the ICU. And they've ultimately, a bunch of these interventions have been combined into what SCCM is calling the ABCDF bundle, or more recently in the PATIS, I forget what they call it, effort management, whatever. So this is an attempt to make it easy to remember. And to me, the way I kind of think of it is the ABCs, and then DEF is sort of separate. And ultimately, all of these things are trying to get you back to your normal sleep-wake cycles, to your own breathing and being off the ventilator, so you can't have a ventilator-associated event, because if you're not on the ventilator, can't have a ventilator-associated event. And if you look at what we do in the ICU, you're on the ventilator, so you get sedation. Sedation sleep is not normal sleep at all, so you're actually kind of getting sleep deprived. And you've got these drugs on board that are associated with delirium, and people keep stabbing you, and so pain is deliriogenic, and so you get this worsening delirium, which means you're less mobile, which means you become more debilitated. And you have this series of events that all sort of come together in longer lengths of stay, higher mortalities, and worse neurocognitive outcomes post-ICU stay. So the ABC component is, the ABC component is about sort of managing meds and getting people awake and off the vent, and then the other stuff we'll talk about a little bit separately. So these efforts actually tend to be associated, there's a hint that these actually are effective. If you look at the percentage of your compliance with the ABCF bundle versus whether or not you survive, you see a somewhat nonlinear relationship between compliance and hospital survival. So if you can get a pretty good percentage of the ABCDF implemented, your patients have a substantially better chance of actually leaving the hospital. And so I think it's a useful tool. So the ABCs, again, this is kind of a tortured acronym. You can think about it any way you want to. You should be thinking about their pain and their airway, and seeing whether or not you might be able to back off on their analgesics or back off on their sedation, moving from narcotics to maybe non-narcotics, maybe moving from sedation to anxiolysis, and something to help people actually get some sleep at night. And once you get to an appropriate point, pairing a spontaneous awakening trial and a spontaneous breathing trial is associated with coming off the vent sooner and an improvement in mortality. There was this period of time where we were really curious about what drugs were most effective in terms of sedating people in the ICU, and the message from really all of that was published, I think, is that using the lowest effective dose for the shortest period of time of the shortest acting drug so that you can turn it off really easily is most effective. And then there was another trial in Spain in the late 1990s that looked at the fastest way to wean people off the ventilator. And it's worth a word about this trial. They randomized people to daily spontaneous breathing trials, so they just turned the vent off and see how they did. Twice a day spontaneous breathing trials. A wean where they just turned the rate at which the vent supported you down several times each day, and then the amount that it supported you in terms of the amount of pressure it applied several times during the day, and see what was fastest. And to get into the trial, you first had to have a spontaneous breathing trial. So these people were thought to be able to be weaned. They didn't think it was time to come off the ventilator. So when they got people who were eligible for the study, they had their spontaneous breathing trial, and more than 70% of those people actually could be extubated. We're terrible at figuring out who actually needs the ventilator. And when I'm rounding the ICU, I frequently ask the resident, depending on how tall they are, do you think you can run a 6 or 7 minute mile? And they all say, I don't know. And to ask them how they'd find out, they said they'd try it. And so I was like, well, does he need the ventilator? I don't know. Well, let's try it. Let's turn it off and see what happens. The endotracheal tube is still there. You can always turn it back. As long as you feel like you've gotten down far enough on their mean airway pressure and their FO2, it is safe to do a spontaneous breathing trial. You can recoup it if you need to. So there's this wake up and breathe protocol, and you'll see in a second how this works in the ICU. The patients have a spontaneous awakening trial safety screen. And if you order it right, this gets taken care of for you. The nurses look and make sure they meet appropriate criteria, and if they pass it, they'll do a spontaneous awakening trial. And if they don't do well with the spontaneous awakening trial, they restart the sedatives at a lower dose and then titrate to a particular goal, sedation goal. If they pass the spontaneous awakening safety screen and they pass the spontaneous awakening trial, they get a spontaneous breathing trial. And again, first they're screened to see whether or not it's safe, if their PEEP is low enough, if their FO2 is low enough. And if they fail, then they go back around. If they pass, they get a spontaneous breathing trial. And if they pass, the respiratory therapist will report out their pulmonary mechanics to you so you can know whether or not it's safe to extubate the person. The delirium assessment, this looks really, really complicated, but if you think about it, it's actually pretty easy. If you have someone who is not totally awake and interactive, all you have to do is test their attention. And the easiest way to test attention, even in an intubated patient, is you just say, squeeze my hand when I say the letter A, and then you spell save a heart, which is pretty easy to remember. And if they make more than 2 errors, then they're screen positive. If they're able to get all the way through that, they're screen negative, and there's probably not a delirium present. And if they're altered level of consciousness, then they have delirium. And you need to think about, how do I intervene? And you intervene both by undoing a lot of the stuff that you're doing and then proactively doing other things. And there are some medications that have been associated, especially with overnight infusions, to help people actually get restorative sleep. There are things like giving them their glasses back and putting their hearing aids in by day so that they can actually be interactive and begin to understand the world around them that could be helpful. And then there are things that you can do by day, like having the lights on and doing their physical therapy, that both help them in terms of preserving their function, but also make it so they're exhausted at night and have restorative sleep. So the delirium assessment can help you begin to understand where they are in terms of how they're thinking, and really trigger us to do a bunch of different interventions. So these are just 2 small things that are among the validated interventions. And if you go through the list of validated interventions is really long, and it can be hard to remember all of this. Sepsis with early resuscitation, antibiotics and source control, ICU patients, this, that, and the other, DVT prophylaxis, et cetera, et cetera. And ideally, there are tools out there that we could use that make it so that we're prompted to think about it. And I would point out the airline pilots do this all the time. They get in before they even get in the airplane, they have a sheet. And for that particular aircraft, for that particular flight, they have this sheet. And they walk around and say, oh, look, that's there, the tank is full, the wheels and make sure that everything is working as it should. And they do an outward inspection. Then they get into the cockpit, and they have their cockpit inspection. They go through that list. And I think we all appreciate that they actually go through that list, because knowing that the tank is full before you get up is a useful thing to know. And we probably ought to think about having our own set of decision support tools. They don't tell you that this is what you must do. They just tell you that we generally think this is best practice, and you ought to think about it. And of course, in the EMR, that decision support, one of the decision support tools is our order sets. So order sets, do they actually work? When you look globally, there is some evidence that order sets will help with compliance with certain guideline adherence. And really the best data comes out of cardiovascular disease. When you look at discharges on aspirin and ACE inhibitors and beta blockers, the use of order sets is associated with more compliance with those interventions. There is some evidence that in hospital, not just at discharge, that the hospitals that use order sets tend to have lower lengths of stay and costs of care for those particular diagnoses. In evidence, in pneumonia, there is better core measures compliance in terms of smoking advice and vaccination and that kind of stuff. And with sepsis, there's some association with improved outcomes with the use of order sets, but I would emphasize I would recognize that association is not necessarily causation. So I'm not saying these are the cure for everything, but I do think that in sort of a hurly-burly world like the ICU, it's nice to actually have a little bit of a roadmap to kind of know where you would like to head. So there are now 3 order sets I would like to highlight. One of them is based in the ER and is the ED sepsis treatment. And you see it prompts the ordering physician to remember to order the lactate, blood cultures, and blood cultures. It doesn't prescribe the fluid resuscitation, which is fine because we use the ultrasound at the bedside and see whether they're likely to be volume responsive. And it doesn't prescribe the antibiotics because you don't know what the source is. But it's starting to get some of these other things that can fall through the cracks and result in sitting only in the denominator rather than having in both the numerator and denominator. These are available in Pelican, so I'm assuming that the people over in Monroe actually also have access. And if they don't, they can let me know, and I can see what I can do about making sure that they do have access. And then Robert Martin put together an order set called Mechanical Liberation Assessment. And this basically is a paired spontaneous awakening trial and then spontaneous breathing trial. Working with some intensivist representatives from each of the adult ICUs, we reviewed a set of orders and made some minor modifications to these, particularly in the spontaneous awakening trials. And so now these are available to you. And it has the nurses see whether they pass a safety screen. And if they pass the safety screen, they will reduce in a set way the sedatives that the person is on. And then respiratory therapy will come around behind them and do some baseline assessment and then do a spontaneous breathing trial and record for you some of those respiratory mechanics, including the rapid shallow breathing index. This is one of the things that we can use to decide to liberate somebody from the ventilator. And they also do a cuff link check. So hopefully by the time you do, if you use this order set, by the time you do rounds, it should be in the chart exactly what their spontaneous breathing trial was, what the results were, and whether or not they had a cuff leak. So while you're standing at the bedside at the end of rounds, you can say, oh, just go ahead and pull the tube, because they're all sedatives, and you know that they would be able to do it. So it should, we're hoping this facilitates care. And then as you know, when you do the ADC, Van Dimmel, or whichever acronym you use to do admission orders, there's an activity thing. And we often just stick in bed rest. And then most people don't think to, I certainly don't, think to reassess that on a daily basis. And so there is now in the hospital the progressive mobility protocol, which again gives nurses criteria to actually decide whether or not these people are appropriate for the progressive mobility protocol, and then gives them the actual protocol by which they can mobilize those patients. So if someone has an EVD, a drain into their brain, that's probably not the person to be walking down the hall, but it has those things that say, don't do this to this person. If they meet the criteria, the nurses won't have to sit there and ask you every day, hey, can we do this? They don't have to wait for PT to come around for that assessment because they don't have any orthopedic injuries. They can get them up to cardiac chair, they can get them standing, et cetera. And hopefully those patients will actually lose less of their functionality and also be more tired at the end of the day, so they actually end up getting more restorative sleep, and as a result are able to leave the ICU faster with less cognitive decline. So one other tool that I want to show you all is, the adult ICUs were really working on getting these cards at the bedside. And Karen Pope, who was an ICU nurse and a flight nurse for a long time, she likes to think of these as like a timeout, only instead of at the beginning of the procedure, at the ending of the rounds on that particular patient, making sure that you go through the ABCDF. Did we talk about whether or not the analgesics are being done? Are they appropriate for a spontaneous awakening and breathing trial? Can we back off on their sedation at all? What was their CAM ICU? Are we doing the right things in terms of making sure this person either we're treating their delirium or making sure that we do everything we can to reduce their risk? What's their mobility order? Is that still the appropriate one? Are we getting them up and out of bed? Are we getting them moving? And do we have appropriate family engagement? And we're hopeful that if we treat this like the timeout at the end of rounding on that patient, the net effect will be that we see a lower ICU mortality, hospital mortality, and better longer-term outcomes. So just to summarize, medicine is pretty complex, and we're learning more and more about what our specific physiologic goals and maybe what the right interventions are, but there are so many different domains that it is hard to remember them all, and we're just human. And I think that we should use the tools that are out there to support our decision-making, not to replace it. I think that humans will always be at the bedside and a central part of the decision-making, but since we're human, I think that we can always do a little bit better. Sepsis particularly is a core measure, and it's a medical emergency. It requires both an infection and organ failure to have the diagnosis. And septic shock, I think it's important to remember that it persists after fluid resuscitation. So you have to make sure that actually a person is appropriately fluid resuscitated before you label them as septic shock. So make sure you resuscitate your patients, give them antibiotics early and culture them, see if it worked, and I would ask that you document that indeed you did actually do those things. In the ICU, lastly, we should use the lowest but still effective dose of all of our interventions, and we really want the patients to stay as close to their baseline as possible. So if they have some COPD and they've got some a little bit of protein calorie malnutrition and they aren't particularly strong, we don't want them to lose any more than they have to being in the ICU. And we do a good job, or do a better job of keeping them as close to their baseline by actually doing things like reviewing their pain control, making sure that they are appropriately controlled but not overly treated, align the treatment with the symptoms, use medicines other than narcotics where appropriate, then try to wake them up every day, try to get them to breathe on their own whenever it's safe, implement the delirium assessment and make sure we prevent and treat where appropriate, get them up and going, and really engage with their families. So that's all I have to say about this effort. Do you have any questions? Sir?
In order to diagnose sepsis and use the SOFA score and you get a PaO2, is there a way to not get an ABG and obtain like about an approximate PaO2?
You can easily. I would argue if their stats are low 90s and around 2 liters, their PF ratio is going to be less than 400. You know, the correlation between FiO2 and especially like nasal cannula and stuff, there's how much of the mouth breathe and that kind of stuff. It's difficult to really know what it is. But, you know, how far down you are the scale, if you're debating, well, is it 200 or 100 on the PF ratio, in all probability, you're getting points over here too, and you're getting the delta of 2 points just by being here or to the right. So I don't think that degree of precision is not. I don't think it's going to be that hard to think. Yes, sir.
Bob, thank you. It's a great talk. As far as in the cardiac world, these order sets do work, but I think we have to be careful that as we drive this, sometimes the institution wants to be efficient. The hospital does. It gets in the way of our care. You know, X-rays at 2 a.m. in the morning. Patients on the floor that get vital signs all night. So we think we're doing better, and these order sets do work, but we have to be cognizant of some of those things where the hospital wants to run efficiently at all times. We have to be cognizant of what our patients are really getting put through. Just a comment.
Yeah, I totally agree, and that's one of the things that I particularly like about the emphasis on delirium. Letting your ICU patients sleep. You know, I don't think the importance of that can be overestimated. And I can prove that in that the fellows are basically healthy, and they're getting woken up every 2 hours. And in the morning, they're pretty much delirious. And so you take somebody who just had, you know, a median sternotomy and everything else, they're going to be out of their head. And we have so many tools in the ICU that are measuring all of those physiologic parameters that we need, that we don't have to mess with. You know, if you have an ART line and a ventilator and a SAT, I don't know that there's any, you know, additional information to be gained by going up to them at 2 o'clock in the morning and poking them and saying, hey, are you in any pain? Well, until you poked me, I was sleeping pretty well. Now I don't know that I am. So I totally agree. I think that efficiency, actually, chasing efficiency can actually result in inefficiency. And if you are waking people up and making them delirious, their length of stay is going to be longer. And so you've got to sort of balance making numbers good versus what really is going to happen. People are going to experience.
So what do you mean by engage with families? What are y'all doing, and how often do you?
So that is our near-term project. Basically, if you look at the physical layout of all the different ICUs, the geography is just totally different from unit to unit. Monroe actually has, I would argue, from a physical plant layout, I think it has the best unit. And the reason I say that is they have a central clinical core, and like the ER, the rooms wrap around, and families enter in from the outside. And so it is easier to have families present through most, if not all of their care, so that families are orienting. If you wake up and you see me at the bedside, it's going to be disturbing. If you wake up and see your wife at the bedside, it's a lot more reassuring. And so it actually there is some very preliminary evidence that it helps with delirium and the like. The Intermountain Health System actually even goes so far, they have open visitation, and that sounds scarier to the nurses than it should. Basically, one person is allowed at the bedside all day and all night. And the PICU actually does a great job of this. Pediatrics ICUs, parents are obviously always there. You never want to pull the parents away. In Intermountain Health System, they have the ICU is designed so there is family space in the room. It's typically out of the flow of machines coming in and out and beds going in and out. But they have their own bathroom, they have a couch that turns into a bed, and they can stay at the bedside, but only one person. So it's not so overwhelming for the nurses. It's not like there are 35 family members all crowded into a room. There are rules about it, but it's open in terms of the hours. And then Intermountain Health System actually has the families participate in multidisciplinary rounds. And they'll sit down at LDS hospital. They have a rounding room in the middle, and then they have the patient rooms around the side. And the nurse, they don't have it's not a full-on teaching hospital. And the nurse will go through the standard presentation, and the family will be present, and they'll come up with a plan for the day. And families are welcome to ask questions and that kind of stuff. And it does slow down their rounds, but it also gets rid of all the questions later in the day. And there's some evidence with needy patients that if you actually schedule them every day for a while, you can then start spreading the visits out because they feel comfortable. They know they have access to you because they were seeing you every day. And similarly, I think that the work hasn't been done to prove it, but I think that if you meet with the families every day, that they know that they're going to get another shot at it tomorrow. And so they're not going to be as needy or as, not going to be asking a whole bunch of different people all the same questions. So they get a single message. They have their opportunity to ask questions up there. It all gets answered, and they're able to move on. So the net effect on their workday is actually it's a time saver, even though in the context of rounds it's a little bit slower. SI is going to need to have substantial revision. It needs to be remodeled before you'd ever do that because you have like seven beds that you could just kind of like run down and touch everybody's toes without going in and out of the door. So you can't have a family at the bedside. There's no room for them to brush their teeth or go to the bathroom or shower or sit or anything. So their visitation would be whatever changes to visitation would be because of the limits of the physical structure. It would be very different than PI, where the kids are at the time it works out differently. So MI is probably the last, but there is a 3-year plan that through this grand shuffling, the trauma burn ends up on 1J, 3G and J are CVICU and SICU, neuro-ICU is where it is, and then it'll turn the attention to MI. And hopefully get rid of those darn posts so that dead space in the room is no longer sitting there. That's what I hear. Does that sound right? Yeah. Any other questions? All right. Thank you all very much.